Hello, all. Thank you very much for your time this afternoon. My name is Kate Bush. I'm the coordinator for programs and services at the ALS Society of Quebec. It's my pleasure to present our professional panel this afternoon. We are going to be starting with Toni Vitale, who's a clinical nurse at the ALS Clinic at the Montreal Neurological Institute. We have Kalyna Franko, who's a speech language pathologist, also at the ALS Clinic at the Montreal Neurological Institute. Karen Lee, who is an occupational therapist at a rehabilitation center in Montreal. Jennifer Barkun, who's an occupational therapist at a CLSC in Montreal. Laura Lindner, who is a social worker at a CLSC in Vaudreuil-Dorion. Danielle Robert, who is a respiratory therapist with the PNAVD in a CLSC in Cowansville, and Carolyn Cooper, who is a nutritionist from a CLSC in Longueuil. Welcome to all of you. Toni, I leave it to you to start the panel. Thank you very much.
So hello, welcome everybody. So I'm just going to talk a little bit about my role. I've made this very informal. I didn't prepare any slides. So basically, as Kate mentioned, I'm the nurse in the clinic at the Montreal Neurological Hospital. And my role is really to coordinate care throughout the trajectory of the illness. I am one of the team members that actually works full-time in the clinic. The rest of my colleagues tend to work not only in ALS, but in the other diseases that we take care of here at the Montreal Neurological Hospital. Part of my role is coordinating care, as I mentioned. An example of that would be, let's say, when we're doing a clinic visit, if falls have been one of the issues that are occurring at home, then one of the things that we do discuss is, would the person with the illness be open to a home care evaluation by the CLSC? And if the person agrees, then we will send a referral to the CLSC. And on that CLSC request, usually I'm also noted as the person to contact, because once again, I'm one who's here full-time Monday through Friday. So even though the questions may be for other team members, often we will tell patients to contact me. And sometimes I can answer the question. Sometimes I will defer to my colleagues and put them in touch with the person with the illness directly. Most of the questions that I do get and that are answered are related to the illness, the medications that we use to treat the illness, care planning, and support. In terms of support, I can follow both the person with the illness and their family member or the support network. But if the needs for psychosocial support are more intense, then I defer to my colleagues either in the community, the CLSC level. Often I will also turn to the ALS Society also, because I think that's one of the areas where there's been a lot of delays and long waiting lists. So that's how basically how we address that issue for support. The other hat that I do wear that is related to ALS, but unrelated to what I've talked to date, is providing education in the community. That means holding or giving presentations at the community level, and also educating students, our future care network, about the illness and what it requires to care for people with ALS. That's about it. So I don't know if there are any questions, or I think we kind of left it informal. If there are questions now or questions later, I'm good with that.
We can ask questions, but I was going to wait to kind of formally do a little block of questions after Karen's presentation.
Oh, perfect. Yes, you did mention that. So okay. That's it for me. So.
Wonderful. Thank you very much, Toni. Kalyna, it's your turn, please. Thank you.
Thank you for the introduction. I did prepare a small presentation about the role of the speech language pathologist. Can someone confirm with a thumbs up that they can see the presentation? Great. Okay, so my name is Kalyna Franko. I'm the speech language pathologist at the ALS Clinic at the Neuro. So I work with Toni closely at the Montreal Neurological Hospital with a focus on changes in speech and communication. Speech language pathologists, just generally to let you know, we're professionals who help prevent, identify, assess, treat speech and language problems, as well as swallowing problems in individuals across the lifespan. So you might have heard of speech language pathologists working in schools, but with the ALS population, we're working in hospitals, rehabilitation centers, some long-term care facilities, university clinics, and also in private practice. And there are no SLPs in the CLSC for adults, so you have to get connected, through your ALS clinic or rehabilitation center usually. There are various changes that can happen in your communication with ALS. The one that we most commonly think of is speech changes. So this is technically called dysarthria, and that's some changes that you might notice if you have a voice that's more hoarse or the volume is reduced. Your speech might be slowed, or there might be some slurring of your articulation. So those are all under the umbrella of dysarthria. Also, respiratory changes can have an impact on your ability to communicate as well. So maybe your voice is softer because you don't have breath support. Maybe also your sentences are shorter because of that. And tracheostomy and ventilation can have a significant impact on your ability to communicate as well. So we work with people to help ensure they can continue to communicate if they have a trach or vent. Cognitive linguistic changes happen in some people with ALS, not everyone, but it can range from more mild changes like searching for your words or being inattentive or impulsive or forgetful, to more severe changes, as in frontotemporal dementia, which is associated with ALS. There can be some changes in your emotions as well, maybe crying or laughing more easily, which can have kind of an impact on your interactions, definitely socially. And there can be other changes as well. Think about if you have hand weakness and it affects your ability to write or type to someone, to communicate with them via text message or on a computer. So these are all under the umbrella of communication changes that I look at with people who have ALS and see what we can do about them. And so depending on the stage of your speech change, there's various things that we would look at together. The question that I most commonly get is, how quickly is my speech going to change? And we really can't predict this. It's a really hard thing. It really varies depending on the individual, and we hope that your speech stays stable and good for as long as possible. And people even in a very early stage of ALS can be referred to us for intervention. Maybe even if your speech is normal, you might consider the possibility of banking your voice or banking some messages for the future if your speech does change. You could record a series of messages that you would like to have saved in case you need to use them in the future, or you could go through a company and send them recordings of your voice, and they create a synthetic voice that sounds like you, so that if you do have to use a communication device in the future, it has that personal touch. So that's someone with normal speech. We might speak about that and help you through that process. And then, maybe there's just a slight change in your speech. And in that case, maybe it's important to register with ALS Quebec and have an I have ALS ID card where people can know why, if you're perchance pulled over by the police, why you have this change in your speech. It could be important to be able to have a medical alert to indicate the reason. If your speech changes further and maybe you need to repeat yourself more often, we're going to focus together on what strategies you can use to compensate for that change in your speech. And we'll talk a bit more about that in the next slide. And then if your speech is much less clear and we need to kind of troubleshoot and see if there's a way for us to have a communication aid that if someone doesn't understand your speech, that you can have another way of communicating. So to briefly go over some examples of strategies that we would use to make your speech as clear as possible. I mean, intuitively, you want to make sure your environment is a good environment for speaking. So being face-to-face with a person, reducing background noise, those little things can make a really big difference. Then for you as a speaker who has some speech changes, you want to try to speak slowly and exaggerate your articulation while you're speaking so that it's as clear as possible. And you might have to repeat if it's needed. And then for communication partners who are listening, you have to make sure you're paying very close attention. You might need to kind of work to clarify If you haven't understood what was said, try to establish the topic of the conversation, or ask some close-ended yes or no questions to see what the person maybe was saying. So, did you say you want to go outside? Yes or no? And then that person can definitively tell you and clarify the misunderstanding. You might also use communication aids. Using some communication aids might also be helpful. If strategies aren't working, you might try writing or texting, or using a text-to-speech application on a communication device, or you might use a mix of both these strategies and also a communication aid, with the goal of, you want to keep communicating. So you have to try to find a way, and that's something that we can do together. So some different low-tech communication aids might be using gestures, or having a wireless doorbell as a call system to get someone's attention. You might also try writing. Here we have an LCD writing tablet, which is easily erasable if you want to write a message on it if someone hasn't understood what you've said. You might also try using a voice amplifier, which can increase the volume of your voice here without any effort. Or, you might want to point to letters using a communication board or an alphabet board, or point to some messages of things that you commonly say. So these are all various options that we can explore together. And you might also opt for something that's more high tech. After all, we all have a little computer in our pocket, right? So high-tech communication aids are speech generating devices. So that means that you can type something or pick a message and it's going to say it out loud for you, which is great because that gets people's attention. You can use that over the phone. And so there are different types of devices that can be used. There's specialized dedicated communication devices with software for text-to-speech and many, many other functions. Or you might use, like I said, your everyday electronic devices like a smartphone or a tablet, and you put on a text-to-speech application such as text-to-speech or speech assistant AAC, where you're able to type a message and it's played out loud. So that's something that we could look at together. But of course, these are not one-size-fits-all solutions. So some people need more assistance with technology. Some people are not able to use it due to hand weakness or other difficulties, language barriers. So these are things that need to be personalized. And people really benefit from working with a multidisciplinary team that's specialized in these high-tech communication devices. And I think my colleague Karen will be speaking more to that soon. So I do recommend referral to a rehabilitation center if you're looking at using one of these types of devices. And that's all that I've prepared for today. So I look forward to working with you all, healthcare professionals, but also people with ALS and families on your communication and maintaining it. Thanks.
Thank you very much. Thank you, Kalyna. So our next presenter is Karen Lee, who is an occupational therapist at a rehabilitation center in Montreal. Welcome, Karen.
Thank you, Kate. So hello, everyone. So I work in the Assistive Technology program at Lindner. Thank you, Kate, for the opportunity so I can present my role as an OT and other services offered by our program. I'll just share my screen. Okay. So in our program, we offer services related to computer access, communication devices, phone and control of environment. Our main goal is to provide recommendation and intervention to help the client to be able to use a computer or a tablet, for example, an iPad, to be able to communicate when it becomes difficult to speak, to be able to access the phone or the cell phone, and to be able to control devices at home, such as lighting or TV remotes. When we first meet the client, we do an assessment of the client needs. We will do an interview so we can know more about the client situation. We'll look at how the client is currently doing, for example, to access the computer or the phone, so we can understand what the difficulties are. We'll do a physical assessment, so we'll know what movements are difficult to do and what we can work with. We'll determine the goals for the interventions depending on the priorities of the client. We will bring different assistive devices for the client to try. If it works, we can do equipment requests. We'll help set up the equipment and we customize the settings to the client needs. We do home delivery, we do installation, training for the client, but also for the family and the caregivers. We will also do follow-up and we evaluate as needed. Technical support can also be given on site or remotely to ensure the device are working well. For example, to make the computer easier to use, we will look at the positioning first, and we'll try to provide support for the upper extremity to reduce fatigue. For example, we can use a lap desk to place the mouse on it. So the idea is to keep the arms closer to the body so the client doesn't need to lift the upper extremity to reach a mouse. Another example is called an ergorest. It can be mounted on the table to provide support for the forearm. We'll also make sure we take a look at the accessibility features inside the client computer or in the iPad or in the phone. It is possible to adjust some settings to make it easier to use. For example, we can change the pointer speed. Then it will require less movements to reach the entire screen. Also, we can adjust the double click when it becomes difficult to do it. We can set up sticky keys so we can press one key at a time. When it becomes very difficult to type, it is also possible to use a non-screen keyboard. When it becomes difficult to use a regular mouse, we will explore alternate methods of access, such as different models of trackballs, or mouses that can be controlled by other parts of the body. For example, it could be a head-controlled mouse, a foot mouse, or eye-controlled devices. Also, some motorized wheelchairs do have a Bluetooth feature, so the client may sometimes use the joystick to control a computer. We will provide the training so the client can learn and practice on using these assistive devices. When the speech is affected, we work along with the speech language pathologist from our team, and together we'll do an assessment. So we will choose the best communication device or application that suits the client's needs. Adapted mouses and communication devices are available through the PMATCOM, the Programme ministériel des aides techniques à la communication. We will make sure the client has access to the computer or communication device or the phone whenever needed. We can use a mounting system to install it onto the wheelchair with the help of a technician from the Technical Aid Service Department, and it is covered by Medicare. If the client needs the computer or the device when lying on the bed, we can also use a floor stand, and it is also provided by the PMATCOM. There are also different solutions so the client can remain independent at home. For example, TV and lights can be controlled remotely through an application on a phone, or we can integrate also the controls into a communication devices. So for more information, you can contact our clinical coordinator. Her name is Marie-Clotilde Grote, and here are her information. Thank you very much.
Thank you so very much, Karen. Does anybody have a question at this moment, either for Kalyna, for Toni, or for Karen? Or shall we just keep on going? I think we can keep on going then. Perfect. Thank you very much. Our next presenter is Jennifer Barkun. She's an occupational therapist at a CLSC in Montreal. Welcome, Jennifer.
Thank you. So as Kate mentioned, I'm an occupational therapist, which I'll refer to as OT throughout my presentation, just shorter and easier. So I'm an OT at CLSC René Cassin in the home care department. So I'm the first one to talk from CLSC. So I'll just explain briefly what we do, what it is for those who may not know. The CLSC is part of the Integrated Health Network, the CIUS. So which involves hospitals, clinics, rehab centers, like some of the previous speakers who are part of the CIUS, and it's by different territories. So I'm part of the CLSC, René Cassin, which covers the territory of Côte Saint-Luc, some of NDG, Hampstead, Snowdon area. And the role of the CLSC is really providing care in the home. So we're the home care department. There are nurses, social workers, occupational therapists, physiotherapists, nutritionists, even some home care doctors. We all work together as a team to meet with the clients, the user at home and their family, and just provide care with the clients. So as an OT in home care, my role is to ensure that the person that you are able to live at home as safely and autonomously as possible for as long as possible in the comfort of your own home. So specifically, I help by recommending equipment, adapted equipment for your home, such as adaptations in the bathroom, in the shower, for like maybe a raised toilet seat if you're having difficulty with strength, getting on and off the toilet seat, bars in the bathroom, and just the general environment. And we can also look at help determine what kinds of mobility aids you need, whether it's if you have difficulty with balance, sometimes there's different types of walkers, or if you have difficulty, more advanced difficulty with balance, we can look at different types of wheelchairs. So the first question, if you have ALS, how do you know when it's time to contact the CLSC, and when do you get involved with an OT at the CLSC? This happens when you start to struggle with doing your basic daily tasks, such as when it's difficult to get into the shower or stand at the sink when you're washing up, or like I mentioned before, if it's harder to get on and off the toilet, or just walking around at home. If that's becoming more difficult, then it's time to get linked up with the CLSC, and especially the OT at the CLSC, like myself. So typically, well, actually, it depends. Sometimes the OT is the case manager in your file. It can also be a nurse or a social worker. And the case manager is the person who coordinates the care in your file. They're like the point person who you can liaise with and speak to, and they help connect you with community resources, like it could be the ALS Society, or they can make referrals to other disciplines and other healthcare professionals, like a nutritionist or a physiotherapist or a social worker. And remember, these people will come to your home. So that's really important, is that when you are linked up with the CLSC, sometimes you can get to the point where it's difficult to leave your home, especially if your mobility is a challenge and you have stairs and it can be difficult to leave to get to appointments. These people from CLSC can come to you. And as a case manager, we also do a global evaluation. So this is like a biopsychosocial evaluation where we do an assessment and we determine what your needs are and make a plan. And the plan describes what we're going to do together to help you. I mentioned I make the referrals, and there's also services as well. So as part of your intervention plan, sometimes we'll recommend that you can have services coming from the CLSC to your home to help you with some of your tasks, like preparing meals if that's becoming difficult. You can have someone come and help you with meal preparation, or help you with getting dressed if that's difficult. So we really tailor your services to what you need. It's very specific to your needs. Okay. And as an OT, in addition to that, I will do a home safety evaluation. So I look further at your home environment and how you manage your day-to-day at home. So I look at, are you having difficulty getting in and out of bed, transferring on and off the toilet? Like I mentioned before, the bathroom is a really major point of what we look at and what we try to adapt. But even getting dressed or taking medications, I look, can you open the pill bottles, or do we need to adapt that to a different way of taking medications? So there's lots of different things we can look at. Even the flooring of your home is something I look at, whether you have carpeting or wood floors, or if there's little threshold steps, like little changes in the height of the floor between the bathroom and the hallway. That is really important because it's going to impact how you move around. And if you're having difficulty with balance or at risk for falls, we really look at a lot of that and adapt it to what you need. So, and that brings me to how I help. So one of the main ways I help is by guiding you in choosing the assistive devices that you need. For example, it can be something as simple as putting out grab bars in your shower to help you be safer when you shower, or a type of chair that you need in the shower, or bars around the toilet, even the bed if you need some bars at the bed, or an adjustable bed. So that's some things we can look at and provide. And mobility aids like walkers and different kinds of wheelchairs. So sometimes the things I suggest can seem overwhelming. It's a lot of changes. Even changing your bathroom setup. I mean, many people don't want it. I wouldn't want to change my bathroom setup. So I can really, it's hard, and people are reluctant to accept equipment, especially if you're young. So that's a challenge. And I work, and I'm here to support you. I work with you to guide you and help make this experience as, a little bit easier, just by giving suggestions and trying to guide you in how to be safe at home. And the last thing I'm going to mention is once the CLSC OT, or once the CLSC is involved, especially as the OT, we typically stay involved throughout your journey. We don't close the file. As long as you're living at home in the community, we're there, and we continue to provide support and change your needs based on what you need and what's happening. So that's it.
Thank you very much. Thank you, Jennifer. Our next panelist is Laura Lindner, social worker at CLSC in Vaudreuil-Dorion. Welcome, Laura.
Thank you so much, Kate. Thank you for the invitation to be here today. Jennifer, I think you did a really great intro as to what services we offer at the CLSC in the home care department. So I am a social worker from the home care department, and I work on a team of professionals like Jennifer and all other professionals that she mentioned earlier. So nursing and doctors and physio, nutrition, and we really make one support system. We make that team so that your time at home is comfortable and that you have everything that you need. So what is it exactly that a social worker does? Someone like me, how can I assist you? How do I assist your families? There's a lot that goes into it. And of course, the main primary thing that we look at is providing emotional support and resources for you and your family. Listen to your concerns, navigate the emotional challenges of ALS, connect you with community resources, support groups, assist you with advanced care planning, ensuring that your values and your preferences are respected all throughout. So that was a bit of a mouthful. I'll go into each of those things so that it's a little bit more clear. But in general, that's really what the social worker does. There is the collaborative patient-centered approach. So our clients are always at the center of every decision. The goal is really to make sure that all of your needs are addressed in a comprehensive manner based on what it is that you indicate is your need, not our own agenda. And it's very important to say that because your voice and your needs need to be validated and heard, right? So emotional support, obviously ALS takes a toll on the body, but also the mind and the heart of you as the patient, but also the family. Social workers are here to provide a listening ear, provide resources to help you navigate that emotional challenge, We encourage open communication with the network of support that you have, so the professionals, but also your family, so that we can have that strong support put in place. Advanced care planning, which is another crucial aspect of making sure that your home care journey goes well. Our team will assist you in making those decisions about care in the moment, but also future care and what your preferences are, ensuring that your wishes and your values are respected. As this disease progresses, these are difficult conversations that need to be had, and you know, what better way to do it with someone who gives you the chance to share really what it is that makes you feel. We want to maintain dignity. We understand that maintaining dignity is the utmost importance to all people with loss of autonomy. And I know that the home care team is really committed to preserving the autonomy and respecting the choices of each individual along their journey. So it's important that that is a part of the intervention when we do work with you and your families. Creating a safe and judgment-free space, having regular family meetings. I think this is often not discussed enough. We often focus on, you know, action, moving things and putting in place, but sometimes it's very important to just pause and say, you know, what is important here? What really matters to each patient and family members? So we like to make sure that there's dedicated time and discussions to ensuring that everyone's voice is heard. Super important. Because sharing the responsibilities can be physically and emotionally draining, right? So caregiver responsibilities among family members is really difficult if it's not discussed and clarified as to, you know, we need to communicate openly who's going to do what your limitations are, where and how much are you willing to do, and then where do we need help. So that's another part that we can put into play, which is looking at other types of support within the home, other types of support connecting with community resources, looking at financial and legal guidance involving disability benefits, insurance coverages, financial assistance programs, if there's any adaptations that need to happen to the home. There are programs and legal avenues that people can take, and the social worker, along, of course, with our OT, can explore those options and see what is available. Practical things like transportation assistance, in-home care support, making sure that you have a caregiver there when your main caregiver is at work or needs to go and do groceries or just simply needs a break and you're not comfortable to stay home alone. Respite care is important. Caregivers play a vital role in the ALS journey, and I think that it's essential for them to have breaks and to take care of their own well-being. So that's a big role that the social worker has, is to make sure that those supports are in place. And of course, emotional challenges for someone with ALS. There's the grief, there's the anxiety, there's the depression. You know, you're often going through a series of losses, including physical loss, loss of your independence, the anticipation of what the future is going to hold. Those are all important things to address should they become concerns or issues for you. And the social worker can help you journey through that, through counseling, through support groups. And what I've done often is, you know, connecting patients with other patients so that they can share stories and share their journey with someone who truly understands what they're going through. In a nutshell, that's pretty much what we offer. I don't know if there was any specific questions regarding some of what I said, but that's pretty much it. We are, as Jennifer stated, in the home care department, we are there to follow you along your journey. You're at home, we're there with you all the way. So, and the privilege is ours, really. Thank you.
Thank you so very much, Laura. Our next presenter is Daniel Robert. He is a respiratory therapist with the PNVD program, which I'll get you to explain, Danielle, in the CLSC in Cowansville. Thank you. Welcome, Danielle.
Hi, thanks for the invite. Actually, just to specify, I actually work with the NPHVA, which the English version of the PNAVD. But primarily, I'm actually working for home care services, CLSC, in my area. It's somewhat of a collaboration, I would say, with the NPHVA. So I'm not being called upon only for the NPHVA. I will be called in the cases of ALS patients for breathing issues when it's starting to becoming an issue. I would say mostly at night, usually, depending on the type of ALS that patients have. But we do get requests directly from either neurology department or pneumology department. And usually when the diagnosis comes from there, it doesn't happen all the time the same way, but there's usually some kind of non-invasive ventilation that's either being at least discussed or it's coming in the near future. So we can actually do home assessments, more of clinical kind of follow-ups, if you wish, and also technical follow-ups when the non-invasive ventilation is actually installed back home. So I do RT or respiratory therapist or inhalation therapist or inhaler. We heard all of them through the years, RT being the official title, but we do installation adjustments of people will often mix up the BiPAP machine and the CPAP machine, which is usually used for sleep apnea. And the difference is actually within the acronym. So CPAP being continuous positive airway pressure and BiPAP being B-level positive airway pressure. So it's just that there's a second set of pressure to really help the patient inflate their lungs properly, because as I often explain to my patients, you don't have a lung disease, you really have a neuromuscular disease, which doesn't give you the enough strength to actually inflate your lungs properly. So that's when the BiPAP actually kicks in. And that's when the NPHVA actually comes into play. It's a national program only in Quebec to provide those equipments for patients, because they're actually quite costly. We're talking around like $4,000 or $5,000. So having that program to provide said equipment gives the chance to the patient to really think about something else. I would say that it takes some adaptation. It's a bit against nature to have a mask onto your nose and mouth to help you breathe. But most of the time people start by using it only at night. It can come to the point where it's close to 24 hours a day. We have some patients going all the way to that point. And that's where I usually say that we come into play from the diagnosis at the really beginning to really the palliative care part of the ALS as well to the end. So we work, as was said before by the previous speakers, we really are part of a team. So OT, nurses, social workers, nutritionist, physio, we're all implicated in following up the patients back home to make their life easier and more comfortable. There are so many different kind of masks you wouldn't believe. So we're usually pretty good with those. If one doesn't work, we can go for another one. We can do some little tweakings on the devices, on the machines to make them more comfortable. And all of that being done in collaboration with all the other members of the team at home. So I don't know if that pretty much sums it up, but yep.
Thank you. Fabulous. Our last panelist this afternoon is Carolyn Cooper. She's a nutritionist at a CLSC in Longueuil. Welcome, Carolyn.
Thank you. I thanks to the team for presenting my job in the CLSC. I think you did a good job of explaining what is the teamwork, and that's the most important part of our journey with the patients, of course. As a nutritionist, and as most of you, as I can hear today, we like to be part of the team as soon as possible in the early stages of the condition, because we want to build good relationships, knowing that sometimes the journey ahead can bring a lot of obstacles, and we want to know the patients to be able to apply the best recommendations to keep the best quality of life as possible. So usually when I come and do my first evaluations with the family and the patients really like us, because contrarily, I'm sorry, my English, but usually nutritionists are often associated to lowering weight and cutting stuff from the food, but the first meeting is often to get people to eat more, to stop thinking about losing weight or fat and reducing the intake. We want to increase the energy intakes, and we want to increase the proteins. Of course, we'll take care of nutrition-related disease. If you have diabetes or something like that, we'll control our recommendations to make it work for everything. I mean, so in the first interventions, we often give recommendations to increase the meals, have smaller meals, but more often enrich your food, often with using more butter, more cream, more sugar if you're not diabetic, because the goal is to maintain the energy, and knowing that sometimes, most of the time, people will lose weight with the time if they can have a bit more weight at the beginning of the journey. Then we keep better energy for longer. If we keep also better weight, we won't have to go so much in the muscles to get the energy, because when you don't have food, you have to get your energy somewhere, and it's not always in the fat that the body gets the energies. Often it's in the muscles. So we want to prevent going into the muscle. And that's why we give a high energy, high protein diet at the beginning. So I try now not to put too much importance on the weight, the number, because I don't want that when people start losing weight, that they say, well, I'm getting depressed because I'm losing weight and I'm doing all the efforts not to lose weight. Because as you know, sometimes you have more trouble eventually swallowing, you have less energy, so the intakes get a bit lower naturally. So we want to try to prevent that as much as possible, but not to put all the emphasis on the number on the scale. Because as I was starting to talk about, and as we talked about dysphagia, that's when the food is getting a bit more problem to swallow, and we don't have the luxury of having a speech therapist at the CLSC, so we can't work with them, but we often work with the OT, the occupational therapist, to evaluate the dysphagia and the people having more problems swallowing. And then we want to adapt the diet. We work a lot with their family or the people that help because we have to adapt the textures of the food. We have a lot of recipes or ways of getting the food to be easier to swallow, but still stay tasty and a pleasure to eat for the patients. We just want to make it easier for the meal, because what we often see is that the meal becomes longer and longer and longer because it's a bit more difficult to swallow. So the meal being longer, often the people will after 20 minutes, a half hour, they'll just stop eating so they don't get the calories that they need because it's much longer. So if we adapt the textures, we adapt the strategies, the feeding strategies by the mouth and at first, then we can maintain the quality of life and the health. The consistency of the drinks also, the water, sometimes it becomes more difficult to swallow. So we can explain how to get the water, the juice, the coffee, even the wine and the beer a bit thicker, so it's easier for the people to swallow and they can keep the pleasure of eating as long as it's possible. As I said, I like to be in the team member as soon as possible because sometimes we have to go eventually to tube feeding. And tube feeding is often, well, I could work with Laura a lot at this moment because the tube feeding is often associated as a difficult way of feeding themselves. They associate it to a failure in the treatment or things like that. So we want to make sure that it's not viewed as an obstacle, but it's viewed as a complementary feeding way, and it can keep your energy. So as I often present the tube feeding, and by the way, with ALS, the tube feeding is more often a gastric way. It's not by the nose. So they have to have an intervention to install the tube. And we don't want to wait too long because we want the people to still have energy and to be able to go through the little surgery and feel healthy. So we have to bring it up as often a bit earlier in our interventions that we might have to go there eventually. And the way I present it is that having the tube feeding, you'll get your energy, you'll get your feeding by the tube, but you'll keep the pleasure as long as possible, because if you can still have 5 or 6 bites, a couple of glasses of your juice or whatever, not glasses, but sips of juice, but you get your hydration and you get your food by the tube, then you can still have the pleasure of eating a few bites. And the other thing that the tube feeding can be very helpful is for the medication, because often the medication by the mouth is harder to swallow. And with the new medication, sometimes they leave a bad taste in your mouth. So at least if you give the medication, and that's the nurse might confirm this, if at least you give your medication by the tube, then you can keep your strength to have the food that you really like. That's a better balance. As I mentioned, I imply a lot the family members because of the family, the environment, and the helpers, because they will have to prepare the food. And sometimes the family, they want more than the patient. So that we have to say, well, you're doing a good job. And you can always give a bit of supplements, commercial supplements. It's going to make you relax, and you'll have 300 calories in a little can instead of a big meal. So we work a lot with the family. We work a lot at their rhythms also, because sometimes they're the one that say, no, I don't want a machine for my tube feeding because we'll see as if we're not healthy anymore. So we have to talk about all this aspect also, and always look at the help that we can bring by the tube feeding or by the different steps that will be together. So nutrition is a part of the team. As we can see, we all have our roles, but I think we all share a lot. We talk about the patients a lot in the corridors and things like that, because we want them to keep the good quality of life. And I think nutrition, being 3 meals a day, every day, for most people, is a good part of that quality of life. So I hope it gives you a better idea, and don't forget to include nutritionists in the team. Thank you.
Thank you so very much, Carolyn. So that is our panel presentation. It's now the time for questions, comments, things like that. Does anybody have a question to start? Since we're a small group, you can just perhaps just open your microphone and then we'd be able to hear your question. Were all of the terms that our healthcare professionals used, were they all understandable? Did you understand everything that was being said? Sometimes jargon comes into play and we're not aware that we've said something that is, took me a long time when I first started at the society to get everything sort of demystified as to who and what all of you did. So this is just still part of my learning now. Yes, Danielle.
I forgot to precise earlier when I was talking about the NPHVA and PNAVD. Actually, another acronym. We're really good with those in healthcare. For those who didn't notice, NPHVA stands for National Program of Home Ventilatory Assistance, which is in French Programme National d'Assistance Ventilatoire à Domicile. So hence the part about the BiPAP, but also cough assist equipment, suction machines, oxygen machine if needs be, although we really seldomly come to that in the end. But those are just little things I forgot to mention earlier.
Oh, thank you. Thank you very much for that. Yeah, I think for anybody who's feeling the need, their respiratory function is diminishing, things like the cough assist and the breath stacking is really important things to know about. So thank you for that. Are there comments? Actually, I have a question, because I guess it's for Toni or for Carolyn, the nutritional needs. When you say you have to increase your intake, I'm assuming it's because there's a more energy being used up with the muscles atrophying. Is that what's happening? Or is it because of lack of use? If one of you could address that, that would be really interesting. Like, how much calories do people need to take in a day in order to maintain their mass?
I will answer and you can complete if you want. Usually the basic metabolism is slightly increased. The efforts for respiration, sometimes you can have some little movements that are tried a lot. And it can be very slight, but just the efforts to repeat and to talk, it can increase your basic metabolism. So we do increase it by at least 20%. So someone that usually needs 2,000 calories, we could increase it to 2,004 calories a day. But I would say that we don't count that much. We go more intuitive.
Mm-hmm.
And from one visit to the other, and I try to get visits as close together, maybe a month at the beginning, and then I can go every second week. And the scale, as much as I don't want to put too much energy on the number, that's the best way to see if from 1 week to the other you lose 4 pounds, then we'll get to increase the intakes with more fat or then go with supplements and things like that. But all the patients that I did see, most of them would lose at least 25% of their weight during the condition, at least.
That's huge. Yeah. Thank you very much. Toni, do you have anything to add to that? No, thank you very much. Does anybody else have questions that for our panelists?
Good.
No, thank you very much, Mr. Galazo.
Yeah, all good.
So I'm not going to prolong this if there's no more questions. I just want to do a heartfelt thanks to our panelists, to Toni, Vitale, Kalyna Franko, Jennifer Barkun, Karen Lee, Laura Lindner, Daniel Robert, and Carolyn Cooper for your time this afternoon. It's wonderful having you as allies, as collaborators in our community. So thank you very much. And for the family members that are here, thank you very much as well for your presence. This webinar will be on our website within a few days. So you'll be able to re-listen to it at your leisure. Thank you very much for your time today. Have a wonderful afternoon, everybody.